Evaluation of prosthetic valve function is an important aspect of follow-up of patients after valve replacement. Clinical parameters would include the careful documentation of symptoms and physical findings. Patients are instructed to listen the valve sounds while in a silent room in case of mechanical prosthesis and to report if the sounds suddenly decrease in intensity. A decrease in intensity of the valve sounds may indicate thrombus formation in the mechanical prosthesis. Normal oscillatory events in case of mechanical prosthesis would include opening and closing sounds with a metallic character as well as flow murmurs, as the prosthetic valve is inherently stenotic. Patient with slowly progressive prosthetic valve obstruction or severe paravalvular leak may present with progressive exertional dyspnea, while presentation with acute pulmonary edema may be the situation in a case of prosthetic valve thrombosis. Embolic episodes can also occur with prosthetic valve thrombosis. Echocardiography, both transthoracic and transesophageal, are the important modalities of prosthetic valve evaluation. Image intensifier fluoroscopy, when available, is useful in visualizing the movement of the valve discs or balls if they are radio opaque. Abnormal movements of the valve stents or cage suggest partial descent of the prosthesis due to slipping of sutures and may be an ominous sign. Fluoroscopy of bileaflet prosthetic valve showing opening and closing movements of both leaflets. Left coronary angiogram can be seen in the background. Though echocardiography is an important modality for evaluation of prosthetic valve, dense shadows in case of mechanical prosthesis can make evaluation of structures and flows behind the valve difficult. Similarly, small thrombi or vegetations attached to the valves may also be missed. Evaluation of the left atrial side of the prosthesis and mitral regurgitation necessitates transesophageal echocardiography in case of prosthetic mitral valve. Aortic regurgitation can be picked up well with transthoracic echocardiogram, as the left ventricle is not within the shadow region. Presence of spontaneous echo contrast in the left atrium should also make one suspect mitral prosthetic thrombosis. The valve gradients across the prosthetic valves are usually higher than normal even for a normally functioning prosthetic valve. A gradient about 10 mm of mercury across the mitral and peak gradient more than 40 mm of mercury across the aortic valve are significant. Highly sensitive Doppler equipment can detect even the normal closure backflow or seating regurgitation with normally functioning prosthetic valves. Pathologic regurgitation, on the other hand, is of high velocity with intense aliasing and often along the wall of the left atrium in case of mitral valve. Coanda effect. It is mentioned that sometimes a paravalvular leak due to suture descents may be laminar and missed. Rocking abnormal movement of the valve ring or stent will be an indicator in such cases. Prosthetic valve evaluation should begin in the post-operative period with careful documentation of findings, including the exact location from which good images are obtained. This is essential to detect changes with time, which might indicate prosthetic valve dysfunction. Intraoperative echo, if available, will be quite useful. In a chronic case of valve obstruction, differentiating between thrombus and pannus is important. Pannus is more often seen in the aortic position and thrombus more in the mitral position. Thrombus is a much more common cause of obstruction than pannus. Pannus is highly echogenic compared to a thrombus. Thrombus is less echogenic and may be mobile. Associated spontaneous echo contrast is another indication of thrombus. Detecting vegetations over a prosthetic valve is another difficult task, requiring familiarity with the normal echoes of the particular valve. Transesophageal echocardiography is useful in this regard because of the higher resolution and the ability to image the atrial side of the mitral prosthesis better. TEE is also useful in evaluating valve ring abscess and pseudoaneurysm. In case of bioprosthetic valves, thickening and calcification or perforation may be noted. Sometimes a flail leaflet may also be picked up on echo. Parasternal long axis view of echocardiogram in double valve replacement. Mitral and aortic valves are prosthetic, as evident from the dense echoes due to the metallic components of the prosthetic valves. Acoustic shadowing is seen below the prosthetic valve. RV right ventricle, LA left atrium, LV left ventricle, Prost MV prosthetic mitral valve. Left atrium is dilated, possibly as a residua of the previous lesions which made double valve replacement necessary. In the still image, aortic valve is in the closed position and the mitral valve in open position. The open tilting disc of the mitral valve is seen as a thin echo in the lower portion of the left ventricular outflow tract with an echo-dense tip. Color Doppler imaging from the parasternal long axis view shows turbulent mitral inflow through the prosthetic mitral valve. Unlike in a normal mitral valve, some turbulence is common in a normally functioning prosthetic valve. A gradient up to 5 mm of mercury may be normal across a prosthetic mitral valve. The color bar at the top corner shows a Nyquist limit of the color flow mapping as 60 cm per second. Hence, any flow with velocity above that will show aliasing. AOV aortic valve. Prosthetic aortic valve in the closed position, seen from the parasternal short axis view. PA pulmonary artery, RVOT right ventricular outflow tract. In this view also, the left atrium appears dilated. Parasternal short axis view frame showing prosthetic aortic valve in open position with a good orifice. The shadows in the upper and lower parts of the aorta in cross section are probably the sewing ring of the prosthetic valve. Video clipping of prosthetic aortic valve in parasternal short axis view. Still images show the prosthetic aortic valve in closed and open positions as seen before. Prosthetic mitral valve with tilting disc in open position seen on echocardiography from a modified apical 4-chamber view. The dense shadow below that is the ring of the prosthetic mitral valve. Movements of the disc can be assessed in this view. The angle through which the disc moves can be evaluated. Here it is about 45 degrees. Prosthetic mitral valve with tilting disc in closed position seen in a modified apical 4-chamber view. Video clipping of the prosthetic mitral valve from the apical 4-chamber view. Opening and closing of the tilting disc prosthetic mitral valve as just described can be seen. Still images showing open and closed positions are also shown. Turbulent aortic flow in prosthetic aortic valve seen from apical 5-chamber view. Some turbulence can occur even without prosthetic valve dysfunction. Basically, a prosthetic valve in the aortic position is always partially obstructive, more so when a small prosthesis is placed as in aortic stenosis with a small aortic annulus. This is often called patient prosthesis mismatch. Hence, it is worthwhile documenting gradients serially so that any significant rise can alert the possibility of new obstruction developing like thrombus or pannus formation. Gradient across prosthetic aortic valve measured from apical 5-chamber view by Doppler interrogation. The gradient here is 37.6 mm of mercury. The gradient is calculated from the velocity using the formula gradient is equal to 4v squared, where v is the velocity in meters per second. Video clipping of turbulent flow across the prosthetic aortic valve. Doppler tracing showing the peak gradient is also seen once again.